السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. This is a video recording for the physiology lecture on coronary circulation in the cardiovascular block. These are the active learning objectives, the intended learning outcomes, the ILOs for this learning activity, and here we have the recommended learning resources. Before describing the coronary circulation in details, we shall first describe how blood flow through the different tissues of the body is regulated. This control of the tissue blood flow is important so that each tissue would receive only a fraction of the total cardiac output. This fraction of the total cardiac output which each tissue of the body receives must be sufficient to satisfy the metabolic requirements of the tissue and supply the tissue with adequate oxygen and nutrients. Otherwise, the tissue would undergo necrosis. Increasing the cardiac output increases the work done by the heart to pump the increased cardiac output. Hence, by controlling tissue perfusion so that each tissue in the body receives just enough blood for its metabolic requirements, cardiac output and the heart work are minimized. Here we have the distribution of the cardiac output during rest and also during exercise. At rest, the cardiac output is approximately 5 liters per minute, and during exercise, as you all know, the cardiac output increases up to 25 liters per minute in ordinary subjects, and it might go up to 35 to 40 liters per minute in well-trained athletes. And here we have the distribution of the cardiac output during rest and during exercise to the different tissues of the body. It is obvious from this figure that during exercise, most of the blood, approximately 80 to 85% of the cardiac output, goes to the skeletal muscles through the arterioles and the capillaries which we have in the skeletal muscles, because the skeletal muscles would require more nutrients and more oxygen supply during exercise. There are three major mechanisms which contribute to the control of tissue or local blood flow. These include intrinsic regulatory mechanisms responsible for the intrinsic or the auto-regulation of blood flow, and we have paracrine regulation of blood flow. And by paracrine regulation, we mean the regulation which is done by paracrine molecules produced by one tissue and help to regulate another tissue of the same origin. So we have paracrine regulators or paracrine molecules secreted from the endothelial cells lining the blood vessels, and these paracrine regulators affect the smooth muscle cells which are present in the walls of the same blood vessels. We also have extrinsic regulation of blood flow, and this extrinsic regulation involves neural and hormonal regulation. Thus, extrinsic regulation of blood flow refers to the control of blood flow by the autonomic nervous system and by the hormones. Let's first describe the intrinsic regulation, the auto-regulation of tissue blood flow. The intrinsic mechanisms involved in the control of tissue blood flow are built-in mechanisms within the individual organs that provide localized regulation for the vascular resistance in that organ, and hence the blood flow through that organ. The brain and the kidneys in particular utilize these intrinsic regulatory mechanisms in order to maintain relatively constant blood flow despite changes and fluctuations in the mean arterial pressure. In this figure, we have on the x-axis the mean arterial pressure in millimeters of mercury, and on the y-axis we have the glomerular filtration rate, which reflects renal blood flow. And as you can see, the glomerular filtration rate, which reflects renal blood flow, is maintained relatively constant despite changes in the mean arterial blood pressure. There are two main mechanisms which have been suggested to explain autoregulation. These include myogenic mechanisms and local mechanisms, local metabolic regulation. Let's now describe the myogenic mechanisms or the myogenic response of autoregulation. The myogenic response is a direct response of the vascular smooth muscle to changes in the mean arterial pressure. And this can occur even in the absence of neural or hormonal influences, which confirms that this is an intrinsic property of the vascular smooth muscle. This action is purely myogenic and no mediators are required. The myogenic response involves stretch-sensitive ion channels which are present in the plasma membranes of the smooth muscle cells in the blood vessels, in particular the arterioles. Thus, when the mean arterial pressure increases, this stretches the smooth muscle cells in the walls of the arterioles, and these smooth muscle cells would then respond by contraction, resulting into arteriolar constriction. The arteriolar constriction protects the small vessels from being damaged, protects the arterioles, and also maintains the blood flow through the tissue almost constant. Because remember, the basic equation of flow states that flow is equivalent to pressure divided by resistance. An increase in the arterial blood pressure would induce vasoconstriction of the arterioles, and when the arterioles undergo constriction, this increases the resistance. Hence, the increase in the pressure then will not result in an increase in the flow, because the increase in the arterial blood pressure would eventually result in arteriolar vasoconstriction, elevating the resistance. So when both the numerator and the denominator are elevated, the flow remains constant. On the other hand, when the mean arterial blood pressure is dropped, the smooth muscle cells in the arteriolar walls relax and the vessels dilate. And when the vessels dilate, the resistance decreases. Hence, the drop in the pressure will not then result in a drop in flow, because the resistance is also decreased as a result of arteriolar dilatation. And as a result of that, the flow remains constant despite the drop in the mean arterial pressure. Now let's describe the metabolic regulation in more details. Reduced blood flow or increased metabolic rate of the tissue allows metabolic byproducts to accumulate. One or more of these accumulated metabolic byproducts acts on the smooth muscle cells of the arterioles, causing the arterioles to undergo vasodilatation because the smooth muscle cells would relax. Vasodilatation increases the local blood flow. Oxygen may act in the opposite manner. In other words, oxygen acts as a vasoconstrictor. It induces the smooth muscle cells in the walls of the arterioles to undergo contraction. Reduced blood flow or increased metabolism reduces oxygen concentration. Hence, reduced oxygen concentration inhibits the oxygen-mediated vasoconstriction. Now, let's describe in details the effects of oxygen in metabolic regulation of tissue blood flow. Under resting conditions, oxygen delivery to the tissue by the blood is matched by oxygen removal to the metabolizing tissue. Hence, there is steady-state oxygen delivery to the tissues under resting conditions. When the metabolic rate of the tissue increases, oxygen consumption by the tissue also increases. As a result of the increased oxygen consumption, the oxygen levels in the interstitial fluid, in the extracellular fluid, decrease. The decrease in the oxygen levels in the interstitial fluid causes the smooth muscle cells in the arterioles to relax, and the arterioles would undergo vasodilatation. Arteriolar dilatation increases blood flow, hence oxygen delivery to the actively metabolizing tissue also increases. Now, let's describe the effects of carbon dioxide in the metabolic regulation of tissue blood flow. In the resting condition, in the steady state, the rate of carbon dioxide production by a tissue is equivalent to the rate of carbon dioxide removal by the venous blood. However, when the metabolic rate is increased or blood flow decreases, the rate of carbon dioxide production by the tissue exceeds the rate of carbon dioxide removal, resulting in the accumulation of carbon dioxide in the interstitial fluid. Hence, the level of carbon dioxide increases in the interstitial fluid, and this acts on the smooth muscle cells of the arterioles, resulting in vasodilatation. The vasodilatation induced by the increased carbon dioxide increases blood flow through the tissue, so that now the rate of carbon dioxide removal increases and matches the rate of carbon dioxide production by the tissue. The increase in the metabolic rate of the tissue or the reduction in blood flow through the tissue also result in the accumulation of hydrogen ions in the interstitial fluid, hence lowering the pH of the interstitial fluid, and also potassium ions and lactic acids accumulate, and accordingly their concentrations increase in the interstitial fluid. These, together with the elevated carbon dioxide in the interstitial fluid, produce relaxation of the smooth muscle cells of the arterioles, hence arteriolar vasodilatation and an increase in blood flow. This figure summarizes the metabolic autoregulation of tissue blood flow and the effects of the different metabolic mediators. Here we have, this is an arteriole, and this is a capillary, and this represents the smooth muscle cells which we have in the wall of the arterioles and precapillary sphincters. With increased metabolism the levels of carbon dioxide, hydrogen ions, potassium ions, and adenosine increase, and they are all relaxant of the smooth muscle cells of the arterioles and the precapillary sphincters. Hence, they all cause arteriolar vasodilatation and an increase in blood flow. On the other hand, with decreased metabolism, the levels of carbon dioxide and hydrogen ions and potassium and adenosine decrease in the interstitial fluid, and now oxygen is available in more than what the tissue requires. And when this happens, oxygen induces vasoconstriction of the smooth muscles of the arterioles and the precapillary sphincters, and the flow is lowered because the metabolism of the tissue was lowered. Having finished with the intrinsic regulation, the autoregulation of the tissue blood flow, let's talk about the extrinsic control of tissue blood flow. The effects of the sympathetic and the parasympathetic stimulation. Most vascular beds are under resting sympathetic constrictor tone. This means that the smooth muscle cells which we have in the walls of the arterioles, even at rest, they receive sympathetic innervation, resulting into partial degree of vasoconstriction. Increasing the level of sympathetic tone constricts the vascular smooth muscle cells of the arterioles more, while reducing the level of the sympathetic tone reduces the level of vascular smooth muscle constriction, and it is as if now the arterioles have undergone dilatation. Most of the sympathetic fibers release norepinephrine, which acts on alpha-1 adrenergic receptors on the smooth muscle cells of the arterioles and the precapillary sphincters, producing contraction. Thus, stimulation of the alpha-1 adrenoceptors by norepinephrine produces vasoconstriction. The coronary blood vessels and the cerebral blood vessels in the brain, they are unique since they are little altered by the sympathetic nerves, and they are predominantly regulated by the local metabolic factors. Adrenaline epinephrine released from the adrenal medulla also stimulates the alpha-1 adrenergic receptors, resulting in contraction of the vascular smooth muscle. The vascular smooth muscle cells also contain beta-2 adrenergic receptors, which when activated produce vasodilatation. The blood vessels in most tissues have more alpha-1 adrenergic receptors than beta-2 adrenergic receptors. Hence, adrenaline, epinephrine, and noradrenaline, norepinephrine contract the vascular smooth muscle cells. Blood vessels in skeletal muscles are unique since they have many beta-2 adrenergic receptors than alpha-1 adrenergic receptors. Hence, the constrictor actions of epinephrine are minimal. Some physiologists also believe that the blood vessels, the arterioles, which we have in the cardiac muscle tissue, the myocardium, also have more beta-2 adrenergic receptors than alpha-1 adrenergic receptors, and we will describe this in more details in the subsequent slides. So we have finished then with the detailed description of the intrinsic, the autoregulation of tissue blood flow, and we have also described the extrinsic regulation of tissue blood flow. The paracrine regulation of tissue blood flow is considered by some physiologists as also an intrinsic regulation of blood flow. The role of nitric oxide as a paracrine regulator of the tissue blood flow was explained in details in the two lectures on the arterial blood pressure and its regulation. We shall now describe coronary blood flow and its regulation. And before we do that, we will describe the unique characteristics of cardiac metabolism, because in the coronary circulation, the most important regulation of coronary blood flow is the metabolic autoregulation. At rest, oxygen consumption by the myocardium is approximately 9 milliliters of oxygen per 100 grams of myocardial tissue per minute. Obviously, more amounts of oxygen are required by the myocardium during exercise. Thus, the heart has the largest metabolic demand per gram of any organ in the body. Energy production in the heart is almost entirely dependent on aerobic metabolism. As a result, the heart extracts a very high fraction, approximately 60 to 70% of the oxygen content of the arterial blood flowing through the myocardium, even at resting conditions. This rate of oxygen extraction of the myocardium at rest is equivalent to the percentage which is extracted by skeletal muscle during severe exercise. Therefore, the coronary circulation is characterized by a low venous oxygen reserve, and extra oxygen requirements for cardiac work upon stress must be then obtained by enhancement of the myocardial blood flow. In contrast, most other tissues under resting conditions extract only about 25% of the oxygen content of the arterial blood flowing through them, and this leaves a considerable oxygen reserve that can be drawn on when a tissue has increased needs. So in most tissues, when they require more oxygen, there is no need to increase blood flow. This is not the case with the myocardium. Oxygen consumption by the myocardium is determined by the intramyocardial tension, the contractile state of the myocardium, and also the heart rate. An increase in afterload causes greater increases in oxygen consumption than an increase in preload does. Thus, deficient delivery of oxygen to the myocardium is more cases in aortic stenosis with increased afterload than in aortic regurgitation with increased left ventricular preload. Adequate amounts of chemical fuel, namely adenosine triphosphate, must be generated by the myocytes in order to support the contractile demands of the heart and maintain its viability. And we've mentioned in the previous lectures that the myocytes have considerable number of mitochondria. Fatty acids, ketone bodies, and carbohydrates are the primary substrates of the heart and are metabolized by the myocytes to generate the adequate amounts of adenosine triphosphate. Optimal cardiac function depends on the efficient matching of the energy generation pathways to the energy expenditure. This balance requires the close communication and regulation of the various metabolic pathways within the myocytes. Fatty acids are considered to be the major source of acetyl coenzyme A for the Krebs cycle and for the oxidative production of adenosine triphosphate in the myocytes. Glycolysis converts glucose to pyruvate and provides a relatively small amounts of adenosine triphosphate to the normal adult heart. So having mentioned the unique characteristics of cardiac metabolism, let's now describe coronary blood flow and how it is regulated in more details. The coronary arteries supply oxygenated blood and nutrients to the myocardium, and when they are functioning normally, they ensure adequate oxygenation of the myocardium at all levels of cardiac activity, in the resting conditions as well as during conditions of stress like exercise. The left coronary artery divides into an anterior descending artery, which is known as the anterior interventricular artery, and a circumflex artery. So these are the two main branches of the left coronary artery. The right coronary artery divides into smaller branches, including the right posterior descending artery, which is also known as the posterior interventricular artery, and the marginal artery. The openings of the coronary arteries are on the aortic side of the aortic valve. They are not facing the lumen of the aorta, rather they are on the aortic side of the aortic valve. The openings of the left coronary artery and the right coronary artery are in different parts of the aortic valve. Here we have the opening of the left coronary artery, and this is the opening of the right coronary artery. Blood flow through the coronary arteries is greatest during diastole due to the recoil of the aorta, due to the elastic recoil of the aorta during diastole, which pushes blood back against the aortic valve and hence pushing blood into the coronary arteries. On the other hand, in systole, blood is moving forward too fast to provide greatest flow. However, the turbulent flow in the ascending aorta pushes some blood back toward the aortic valve and into the openings of the left and right coronary arteries. The main coronary arteries feed transmural arteries. These are transmural arteries. The transmural arteries plunge into the muscle cells of the ventricles, into the myocytes. Transmural arteries supply arterioles which control blood flow to the coronary capillaries. There are approximately 4,000 capillaries per cubic centimeter of myocardium. In fact, each myocardial fiber, each myocyte has one capillary. The ratio of the myocytes to the blood capillaries is 1:1. So this is because adequate blood supply to the myocardium is important. Inadequate blood supply to the myocardium results in myocardial ischemia, and when severe, results in myocardial infarction, MI. The right coronary artery has a greater flow in approximately 50% of the population, while the left coronary artery has a greater flow in about 20% of the population, and in the remaining 30% of people, flow is equal in both the left and the right coronary arteries. Coronary blood flow at rest in humans is approximately 250 milliliters of blood every minute, and this is equivalent to 5% of the cardiac output. Thus, the heart receives approximately 5% of the cardiac output at rest, and we mentioned this at the beginning of the lecture. Most of the venous drainage of the heart returns through the coronary sinus and anterior cardiac veins. So we are still describing coronary blood flow, and when we finished with this detailed description of the coronary blood flow, we shall describe how coronary blood flow is regulated. At rest, as we mentioned earlier in the lecture, the myocardium extracts 60 to 70% of the oxygen content of the arterial blood flowing through the myocardium. Why is this the case? This is the case because the heart has more mitochondria. Approximately 40% of the cell volume is occupied by mitochondria. This high number of mitochondria is important to generate the energy for cardiac contraction by aerobic metabolism. When more oxygen is needed, as during exercise, coronary blood flow should increase because there isn't much oxygen reserve in the blood which flows away from the myocardium even at rest. Now let's describe the regulation of coronary blood flow. Coronary blood flow has got autoregulation by physical factors and by myogenic mechanisms and metabolic factors or metabolic control. Coronary blood flow has also intrinsic regulation in the form of nervous control. Coronary blood flow is also regulated by nitric oxide, and this form of regulation is considered as a paracrine regulation mechanism. It is important to note that the constriction and the dilatation of the coronary arterioles is governed primarily by the metabolic regulation. Thus, local regulatory mechanisms regulate the amount of blood flow to the myocardium in a manner that matches the amount of oxygen delivered to the myocardium with the amount which the myocardium needs based on the oxygen requirement of the myocardium. We shall now describe the mechanisms responsible for the control of the coronary circulation, the mechanisms which are involved in the control of coronary blood flow in more details. And we shall begin with describing the physical factors. The coronary perfusion pressure is the pressure responsible for perfusing the myocardium with oxygenated blood and nutrients. Hence, it is a very important pressure in the coronary circulation. This pressure is influenced by the aortic pressure and the direction of blood flow in the ascending aorta. In systole, the aortic pressure is highest, but the direction of blood flow, the direction and velocity of blood flow limit the coronary perfusion pressure. Additionally, the turbulence of the blood flow in the ascending aorta during systole limits the coronary perfusion pressure. On the other hand, in diastole, the aortic pressure is lower than the aortic pressure in systole. However, the coronary perfusion pressure is greatest due to the recoil of the aorta back during diastole, hence pushing the blood back against the aortic valve and against the openings of the coronary arteries. This figure demonstrates coronary blood flow through the left anterior descending branch of the left coronary artery during the cardiac cycle, and also changes in the aortic pressure during the different phases of the cardiac cycle. So on the x-axis we have the time. As you can see here, during the isometric contraction phase of ventricular systole, flow through the left anterior descending branch of the left coronary artery is minimal, and the aortic pressure reaches its minimal level, which is 80 millimeters of mercury. Now, as ejection of blood begins from the left ventricle into the aorta, the aortic pressure reaches a maximal level of 120 millimeters of mercury during the rapid ejection phase, and then decreases a bit during the slowed ejection phase before the left ventricle finishes with its systole. In here, in the flow through the left anterior descending branch during the ejection phase of the cardiac cycle, the flow increases, is better than the flow during the isometric contraction phase. However, the flow doesn't yet reach a high level. It is only during diastole here where left ventricular diastole begins and the aortic pressure begins to decrease. This is the isometric relaxation phase of the cardiac cycle, where the flow through the left anterior descending artery reaches its maximal level. Hence, flow decreases as the aortic pressure decreases, because as the aortic pressure decreases during diastole, the coronary perfusion pressure also decreases. It is thus evident that there is phasic pattern of coronary blood flow with much reduced flow during systole, and this is what is physiologically known as the systolic crunch, where the coronary blood vessels are squeezed during systole. Most of the coronary blood flow, about 70% of the coronary blood flow, occurs during diastole, and flow is driven by the aortic pressure, with the flow declining as the aortic pressure drops throughout ventricular diastole. On the other hand, only 30% of coronary blood flow occurs during systole. Blood supply to the myocardium is thus substantially reduced during systole as a result of squeezing of the intramyocardial coronary arteries during systole, and this phenomenon is physiologically known as the systolic crunch. The systolic crunch results in coronary extravascular resistance. The contraction of the ventricular muscle during systole squeezes the intramyocardial coronary arteries, and hence increasing the resistance to the flow through the intramyocardial arteries, through the transmural coronary arteries. The contraction is greatest near the endocardial surface. Thus, this region of the myocardium has the greatest systolic crunch, and the greatest resistance to coronary blood flow is also found in the subendocardial region of the heart. Hence, the majority of myocardial infarctions begin at the endocardial region of the heart. This figure demonstrates the effect of systolic crunch on right coronary artery flow and left coronary artery flow during the different phases of the cardiac cycle, with much reduced flow through the left coronary artery during left ventricular systole, especially the isometric contraction phase of systole, and with increased flow during diastole. This figure also demonstrates that systolic crunch has the biggest effect on the left ventricle, which has more muscle and generates more pressure. Flow through the left coronary artery is much reduced during systole, whereas there is little noticeable effect on flow through the right coronary artery. The ventricular myocardium shows reactive hyperemia as a result of the systolic crunch, where occlusion of the flow during the systolic crunch would produce metabolic wastes which act to dilate the blood vessels and hence increase blood flow. We will explain the metabolic regulation of coronary blood flow in more details in the subsequent slides. Blood flow to the left ventricular myocardium is decreased in patients with aortic stenosis because of the increased left ventricular afterload. In aortic stenosis, the left ventricle must work harder in order to generate much higher pressure to overcome the resistance of the stenotic aortic valve in an attempt to maintain the stroke volume. Consequently, the intramural, the transmural coronary arteries are severely compressed during systole. Thus, patients with aortic stenosis are more prone to develop myocardial ischemia and myocardial infarction. So we have finished with the physical factors affecting coronary blood flow, and now let's describe the myogenic coronary autoregulation. This figure demonstrates the myogenic coronary autoregulation with the coronary perfusion pressure on the x-axis and coronary flow on the y-axis. We can have the mean aortic pressure, the mean arterial pressure on the x-axis instead of the coronary perfusion pressure. This figure demonstrates that coronary blood flow is maintained nearly constant over a range of mean aortic pressure, usually 60 to 140 millimeters of mercury. Above or below these limits, autoregulation, the myogenic coronary autoregulation fails and coronary blood flow increases or decreases in a linear fashion with the corresponding increases or decreases in the coronary perfusion pressure or the aortic pressure. Thus, as the mean aortic pressure increases, the increased aortic pressure or the increased coronary perfusion pressure stretches the coronary arterioles, and when the arterioles are stretched, they undergo arteriolar constriction, increasing the resistance, hence maintaining the flow constant. And as the pressure, the mean pressure increases further and further, the arterioles undergo more and more vasoconstriction and increasing the resistance more and more and keeping the flow constant. This is the autoregulatory curve with increased metabolism. So coronary blood flow increases but still is maintained nearly constant over a range of mean aortic pressure of 60 to 140 millimeters of mercury. Now let's describe the metabolic control of coronary blood flow, which is the most important regulatory mechanism of coronary blood flow. Constriction and dilatation of the coronary arterioles is governed primarily by local regulatory mechanisms. These local regulatory metabolic mechanisms regulate the amount of blood flow to the myocardium in a manner that matches the amount of oxygen which is delivered to the myocardium with the myocardial oxygen demand. When cardiac work increases, the coronary blood flow is increased and the opposite is true. Thus, myocardial oxygen requirement is the single most important factor determining the rate of coronary blood flow. Coronary vasodilators during increased activity include local hypoxia, adenosine, nitric oxide, increased partial pressure of carbon dioxide, increased hydrogen ion concentration lowering the pH, increased potassium ions concentration, prostaglandins, which is prostaglandin I2, the prostacyclin, and histamine. Nitric oxide is an important coronary vasodilator, and we have described the mechanism of action of nitric oxide in the previous lecture. Now let's describe the adenosine hypothesis. The myocardial cells, the myocytes, need oxygen to convert adenosine diphosphate to adenosine triphosphate. When oxygen is low, adenosine diphosphate is converted to adenosine monophosphate, which is broken down to adenosine. Adenosine is lipid soluble, and it crosses the plasma membrane of the myocytes and acts on receptors in the smooth muscle cells in the arteries and arterioles, resulting in vasodilatation and increased coronary blood flow. Now let's describe the extrinsic regulation of coronary blood flow, the nervous control of coronary blood flow. Coronary arteries have both alpha-1 and beta-2 adrenergic receptors. You all know that stimulation of the alpha-1 adrenergic receptors causes vasoconstriction, while beta-2 receptors activation causes vasodilatation. Experimental direct stimulation of the cardiac sympathetic fibers causes coronary vasoconstriction due to the presence of more alpha-1 receptors than beta-2 adrenergic receptors in the coronaries. This is one view. Some physiologists do not believe in that and actually believe that the coronary arteries and arterioles have more beta-2 adrenergic receptors than alpha-1 adrenergic receptors. However, now let's believe that coronary arteries and arterioles have more alpha-1 adrenergic receptors than beta-2 adrenergic receptors. Thus, with stimulation of the cardiac sympathetic fibers, there is coronary vasoconstriction. If we assume that the coronary arteries and arterioles have more alpha-1 adrenergic receptors than beta-2 adrenergic receptors. However, during physiological conditions of enhanced sympathetic activity, the heart rate and the myocardial contractility are both activated by the cardiac sympathetic nerve fibers, and also blood catecholamines on the myocardial beta-1 adrenergic receptors. The resulting increase in cardiac metabolites induces vasodilatation, which overrides the direct constrictor effects of the sympathetic fibers to the vascular wall, with a net increased coronary blood flow. Thus, it is evident that such extrinsic control can be overridden by the local cardiac metabolic state, by the metabolic regulation. The other view is that in the myocardium and in the skeletal muscles, the blood vessels have more beta-2 receptors than alpha-1 adrenergic receptors. Hence, epinephrine promotes vasodilatation. In most other tissues, the smooth muscle cells of the arterioles have more alpha-1 receptors than beta-2 receptors. Thus, epinephrine promotes vasoconstriction. Parasympathetic stimulation of the heart causes modest coronary vasodilatation due to the effect of the released acetylcholine on the coronaries. However, if the parasympathetic activation of the heart results in a significant decrease in myocardial oxygen demands as a result of reduction in the heart rate, then intrinsic metabolic mechanisms will increase coronary vascular resistance by constricting the coronary blood vessels. In short, sympathetic activation to the heart results in coronary vasodilatation and increased coronary blood flow due to the increased metabolic activity. due as a result of the increased heart rate and increased myocardial contractility. On the other hand, parasympathetic activation of the heart results in a significant decrease in myocardial oxygen demand as a result of the reduction in the heart rate, and so decreases coronary blood flow. Remember, parasympathetic stimulation doesn't have influence on ventricular contractility. Finally, let's very briefly describe an important disease which affects the coronary arteries, and this disease is clinically known as coronary artery disease or atherosclerosis, which is characterized by the formation of atheromatous plaques in the walls of the coronary arteries, hence resulting into narrowing of the coronary arteries, and there might be also the formation of blood clots on top of the atheromatous plaques. This disease has risk factors. These risk factors are conventional risk factors and modifiable risk factors. The conventional risk factors include older age, so this disease is common in men who are over 40 years old and in women who are over 55 years old. Family history of early heart disease is another conventional risk factor of coronary artery disease. The race is another conventional risk factor, since it was found that among patients with coronary artery disease, the cardiovascular death rates for African Americans are reported to be particularly high. The modifiable risk factors of coronary artery disease include high blood cholesterol levels, especially low density lipoprotein cholesterol, high blood pressure, cigarette smoking, and it was reported that cessation of cigarette smoking is the single most important preventive measure for coronary artery disease. Diabetes mellitus is another modifiable risk factor. Obesity is another modifiable risk factors. Lack of physical activity, the metabolic syndrome, and mental stress and depression. Here we have the ECG changes which we see during exercise in a patient with coronary artery disease resulting in myocardial ischemia. So at rest, there are no noticeable ECG changes. However, when this subject or when this patient undergoes exercise ECG, there is significant horizontal ST segment depression. These patients with coronary artery disease are also very prone to develop myocardial infarction. And here we have the ECG findings of an inferior myocardial infarction, where the changes of myocardial infarction are seen in the inferior leads, are seen in lead 2, lead 3, and AVF, and these changes are in the form of initially the T wave becomes peaked T wave. This is known as hyperacute T wave. Then the ST segment elevates, and this is followed by the ST segment goes back, and there is development of pathological Q waves and inversion of the T waves. These ECG changes in acute myocardial infarction will be described to you in details in future blocks, and that's the end of this important learning activity. And here we have again the intended learning outcomes, the ILOs, and thank you very much for listening.